Good evening and welcome to the last session of the day. And I'm sure that there are many of you that are here because we all want to know about brain tumors, benign and malignant, pediatric and adult. And I'd just like to introduce our facilitators, Dr. Tarendri Naika, good friend of mine and colleague, and Dr. James Balugan. Thank you for availing yourself. We're certainly looking forward to your talk, so please go ahead.
Thank you, Zainab. Good evening, everyone. I'm going to introduce the first speaker, but I just wanted to say good evening on this late Sunday. We've got a lovely lineup of speakers tonight. One of our speakers, Dr. Bathaji, gave his apologies, but we hope that you'll still be enriched by the talks that are coming. And this session, the second neuro-oncology session in aortic, will forge the way for more collaboration and research on the continent. SNOSA is a big part of the African neuro-oncology, and our next speaker is the president of SNOSA. So without further ado, let me introduce my co-facilitator, Dr. James Balogun. So James did his neurosurgery degree at the University College of Ibadan, and then did his fellowship in skull-based surgery in Canada at Sick Kids in Toronto, and then another fellowship in Pittsburgh. I know him as my friend and the president from SNOSA at our first meeting in Abuja in 2018. So I'll hand over to James. He's going to be talking about non-functioning pituitary adenomas, a benign but morbid disease. Thank you, James.
All right, thank you very much, Joanne, for your kind introduction. It's a pleasure to be here once again and to be part of the second session of neuro-oncology in the aortic. I think it's a big thing. That SNOSA is a part of this, and obviously we will continue to collaborate as we go on. I guess my talk is just a short talk to kind of much more raise awareness about this disease before we then dovetail into some of the real meats of the talks for this evening or for this session. So obviously we all know it's pituitary adenoma, but then I titled it Non-Functional PITNET, a benign but morbid disease. I have no disclosures. So basically I work at the University College Hospital in Ibadan in Nigeria. Just a background and a quick one. Obviously, the incidence has been quoted as 15 to 20% in the general population. And sometimes it's also quoted that this is 15 to 20% as well when you look at all of tumor series in most places. Obviously, we do know that the commonest tumors generally are gliomas, but then we tend to see this particular disease from the pituitary much more common than most people realize. They obviously from the adenohypophysis, and they're generally really benign, which is why most of the times we talk about pituitary adenomas, but we do know that the carcinomas do exist. But then the benign ones, as we call them, they do present with various behaviors with respect to being differently invasive. Some are actually aggressive, and like I mentioned earlier, very few are malignant with metastasis. There has been efforts at different times to kind of, whether molecularly or even image-wise, decide how invasive some of these tumors are and to be able to predict their aggression, both from imaging as well as the molecular markers. We haven't really succeeded with molecular markers to really be able to really cut down to predict them, but obviously the change that was brought about from the 2016 down to 2021 WHO classification of tumors of the nervous system thus continue to push the frontier. So in this latest classification, we have a change in paradigm from calling it pituitary adenoma because obviously the pituitary tumor, the fact that this tumor should actually be classified as part of the neuroendocrine tumors, and therefore there's a renaming. Hopefully this is going to be further validated when the blue book comes out as the PET-NET. So this completely changes our overviews of what we're dealing with in terms of tumors of the pituitary gland. Obviously now there's an effort to kind of morphologically classify them as well as functionally based on certain transcription factors and not just whether they produce hormones. Obviously, we know that the common ones are the non-functioning, but then you do have the functioning ones, which will then produce particular types of syndromes. But then looking at the classification based on the transcription factors, we do know that the lactotrophs, somatotrophes, and heterotrophs do come from the same lineage. And obviously the gonadotrophs do come when you find SF1 lineage. And thus, when you do immunohistochemistry, you get an SF1, obviously, that would point to more like a gonadotrophs. Obviously, gonadotrophs are the most common type of non-functioning PIT-nets, but then we do know that the ones from the PIT1 lineage and TPIT lineage are usually the silent ones. Again, whether they're invasive is again varied. But then the common tumor, which actually was a lot of debate, there was a lot of debate about it, was the null cell or immunonegative tumor, with respect to the fact that initially nobody wanted to agree that null cell could actually really be classified as an entity, because to classify it, the tumor would not secrete any hormones, as well as there would not be any identification of transcription factors in those tumors. Obviously, way back in Toronto, we did publish a paper on null cell adenomas and how invasive they are compared to gonadotrophs and how their growth rate do differ, even though these two tumors generally would compose of the most common tumors that you have of the pit or pituitary tumors. So in the WHO 2016-70 classification, we do realize that the very silent corticotroph and when lactotrophs do occur in males, and then the Crook cell and all the plurihormonal PIT1 positive tumors, they generally are considered high risk because of their invasion and their aggressiveness. Therefore, the tendency to recur. So we do know that clinical presentation generally for non-functioning is basically from pressure effect, and most of them with all kinds of visual symptoms from reduction in visual acuity to restriction in the visual fields or cranial neuropathies, especially if they do present with pituitary hypoplexy. Hormonal dysfunctions are generally more with those who are secreting tumors. And of course, there has been an argument that it's actually a spectrum from the secreting tumors to the functioning to the non-functioning, because we do have silent tumors that actually secrete tumors and then can really result in the syndromes that we have been that can identify some of these particular lineages. Obviously, this is more uncommon. It is more uncommon to present with CSF lake as opposed to when a patient does have craniopharyngioma. Again, this is just background diagnosis. Again, it's key neuro-ophthalmology. You got to be able to look at what the vision of the patient is, and key, particularly in this part of the world, is usually also that we need to measure the neuroendocrine evaluation, and basically because of the kind of tumors that we see. The imaging modalities, obviously, the preferred would be MRI. Again, when you talk about MRI, the greater what the Tesla is, the better what the machine is, and then how many cuts or how low the cuts you can have. Obviously, with some of those lower magnet MRIs, most you will get 5 mm. It's usually more difficult for you to get 1 mm and 2 mm cuts, but with a higher Tesla MRI, like 1.5, you probably get very thin cuts, which kind of gives you that opportunity to really evaluate the tumor and plan. Obviously, we do use imaging to classify them into microadenoma, which means that the tumor size at its widest diameter will be less than 10 mm, and macroadenoma greater than 10 mm, and then giant adenomas usually, again, we will say more than 25 mm, but then there's obviously a change and move towards the fact that we should actually classify it above 330 mm, which is 3 cm, and then 40 mm, which is 4 cm. Not a boy, obviously, there are different ways to manage this tumor. The traditional way before now used to be the craniotomy and tumor excision. We then went on ahead to do microscopic transfemoidal, which some of the old school neurosurgeons are still very, very conversant with. There has been argument comparing microscopic transfemoidal with endoscopic endonasal. Obviously, the endoscopic endonasal does have its advantages, but in terms of outcome of treatment, they have stood at par with each other. But then we do know that in terms of discharge, how many days patients spend in the hospital, in terms of gross total resection, people tend to lean more on endoscopic endonasal. And there's also a transformation of the field with the fact that we can then have a 3D of endoscopes, and then we can better view things. Obviously, there's still room for radiotherapy and as well in its various forms. Obviously, in most parts of Africa, you will still generally use what is traditional and stereotactic radiotherapy in terms of gamma knife and linear accelerators are just beginning to find their way on the continent, particularly in the north and the south and part, obviously, of West Africa. So we do say that to have a contemporary care of PNETs, it must be multidisciplinary care. Neurosurgeon sees the patient, or the ophthalmologist sees the patient first, thanks to the neurosurgeon. The endocrinologist has to be part of the care, both pre-op and post-op. The neuroradiologist helps to classify what the tumor is in terms of invasiveness and aggression. And obviously, it's important that the radiation oncologist also be able to have a word with respect to if you have a subtotal resection, how far it is from the optic chiasm, and whether that would not jeopardize patients' vision. And of course, you do have specialist nurses. Okay, most of the times it is advocated that you have a joint clinical evaluation by everyone involved, especially the neurosurgeon, endocrinologists, and nurses, and do have tumor boards running particularly focused on this tumor. So what I intend to do is just to bring to you the symptom boarding. Again, most importantly, if you look at data from a Nigerian publication way back in 2010, and this hasn't changed. We have a series running in my house with respect to how the vision, the level of visual deterioration that the patients present with. 44% of patients will come in with impaired vision, and truly a huge number of them, 30%, or of those who come in with visual problems would actually be blind, either in one eye or two eyes. So even when they're not completely blind. Obviously, if you follow the real definition of blindness, perception of light is really not some vision, even hand movement. And so if you put all of those together, only very few patients coming with what is useful vision that you probably can preserve post-surgery, because these patients do come in late. For most of our series that we've had, a first impression was the fact that most tumors are generally in the range of 2.5 to 3 centimeter in their widest diameter, which means that they're actually very big or giant tumors that present to us in this part of the world. And then when you juxtapose that, we're trying to do an endoscopic endonasal procedure, or you obviously know what the risks are and what the outcomes would be with respect not just to the risks of death, but with respect to morbidities from CSF leak, as well as worsening vision and to post-resection apoplexy of tumors that are remaining. Obviously, these have to compete with all the kind of variation of tumors that we see from anterior cranial fossa to posterior cranial fossa. So you have to. So most of the times you find people, it's the same neurosurgeon in this part of the world who would deal with all the tumors. Obviously, in some climes like North Americans, And in the UK or the European countries, you do have people who are focused on just pituitary tumors or perhaps skull-based endonasal or endoscopic procedures. So we do have not all bleeds. We did have a recent publication in World Neurosurgery of a recent experience of an endoscopic endonasal transperineal surgery in West Africa, and the report of 56 cases. They had pretty decent gross total resection, obviously in the range of 40 to 50%. And that's fair enough for those, if you look at the learning curve of what it takes to really do an endoscopic endonasal procedure on these patients. We do hope that very soon we'll be able to release our data to also complement this experience, obviously from part of West Africa. Just to give you a case snip, a snippet, a 55-year-old female, progressive visual tumor, obviously with complete encycling of the internal carotid artery. You're faced with that as part of your first procedures in doing an endoscopic endonasal procedure. You can see how huge the tumor is. Obviously, again, pushing the third ventricle posteriorly, and then we were able, obviously, we wouldn't go after the one in the cavernous sinus, but obviously we had a very, very decent resection, and leaving just a part of that and cycling that internal carotid artery in the cavernous sinus. Patient's vision obviously improved bilaterally, no complications, no CSF. And this is the challenge here facing the surgeons here. Obviously, is the fact that you also don't have all that you require, even from basic control of hemostasis to sealants that you need. And I do know that some people who do endoscopic in this part of the world still struggle even to have a drill that is adaptable to drilling some of the bones that you need to drill to get up there to the tumor. Again, this is not a disease of just females. So 61-year-old male who also presented with headaches, progressive visual loss, barely counting figures. In the, we opted rather than do transcranial to do an endoscopic procedure. And then obviously we did have very, very distant resection of the tumor. Vision obviously improved post-op. He did have any intervention without the use of lumbar drain. So again, I think that getting to know some of those procedures and having people who can practice them would be really key for the continent. So I do think that calling attention to this tumor, we need to move in almost all of the countries towards early identification to prevent these kind of huge tumors, as well as they're losing their vision. Multidisciplinary care of the patients, in training of all the specialties, and of course, by the neurosurgeons and ENT, and we must move from just making that diagnosis histologically of pituitary adenoma, which at this point in time really makes little sense. We need to patients of the tumor with whatever basic resources we have, and these obviously regions of the continent. I do think that the fact that we aren't where we are should be enough motivation for us taking care of these patients and continue to push forward. I want to thank you for your attention. Like I said, thanks for listening. Basically, I'm going to unshare my. All right, so having finished my presentation, I'm going to again call on my co-facilitator, Charan, who is a radiation oncologist in Cape Town. She's a very good friend, and like she introduced, so she's been introduced twice by Zainab, and then I'm doing the second introduction now. A very fantastic radiation oncology. So she will be taking the second presentation. Turan, please go ahead.
Thank you, James. Your sound was breaking up a little bit there. So if you struggle, you might need to turn your camera off, but let's see how we go. Hopefully my sound's coming through well. I'm just going to share my screen. Just want to check, can you see my screen, James? Can you see my screen? Okay.
Yes, we can.
Okay, perfect. Okay, so good evening again. I'm going to speak about pediatric brain tumors.
Starting to, okay.
James, you all right? You were saying something?
Okay. Now I'm fine. Go on, please.
So yes, I'm going to talk about the outcome in pediatric brain tumors following radiotherapy. This is a huge topic, and I have 8 minutes, so I thought I'd just give you little snippets of detail. We're currently actually analyzing all of our brain tumor patients, but I'm just going to give you small pieces of information from our medullo and ependymoma group, but also just tell you a little bit about our department. So I work at Curtis Geer Hospital, which is a university referral center attached to the University of Cape Town. And just a bit of background, pediatric brain tumors, obviously a common solid tumor in this age group. And the cure rates can be favorable if you've got a referral center that's good at looking after these tumors. But often with the use of surgery, radiotherapy, chemotherapy, and the expertise that goes with it, the difficulty comes in trying to exploit this balance between aiming for these high cure rates and trying to minimize the acute and late toxicities from the treatments that come with this cure. So factors influencing the degree of the neurological deficit for children with brain tumors. Obviously, the size and location plays a big role. For the pediatric population, the age at diagnosis has a huge effect because of the development of the brain makes a difference, and it will tolerate the different insults from the tumor, surgery, and radiotherapy better if the child's older, usually. And then obviously, whether radiotherapy, chemo will be needed plays a role, because if you have like a grade 1 JPA that's dealt with surgery alone, then there's 2 less insults to that brain. And then the child's pre-morbid function needs to be taken into consideration. So just to say, we are privileged at Curtis Geer. Our pediatric neuro-oncology MDT has all the expertise we need. So we have treatment and follow-up clinic that happens with all of our pediatric brain tumor patients, and we have a pediatric specialized neurosurgeon. Myself and Professor Parks are the radiation oncologists, and then we follow these patients up with an educational psychologist. And the pediatric oncologists, radiologists, and endocrinologists are vital. So ideally, in the perfect world, if you want to look after pediatric brain tumors, these are the role players you need to have a proper MDT. This is not always possible in Africa, and often you'll find that the radiation oncologist is also giving the chemotherapy. And if this is necessary, then that will have to do. But ideally, if you can partner with an MDT or a tumor board that advises, then you will have at least some support. And that's what we're trying to do now with different sister meetings in the pediatric community. What you don't see on the slide, and what we are also privileged to have, is a pediatric anesthetist. So what we have at Curtis Geer is a half-day list every day that starts at 1 o'clock, where the pediatric anesthetist will come and sedate all children requiring a general sedation for radiotherapy. This is not a full general, and the child's allowed to eat in the morning and then just has clear fluids. But what we found is there's a drug called dexamethasone, also known as Precedex, and this allows you to do non-painful sedation. So we've got a very smooth pediatric sedation that's running daily for our radiotherapy. So that's something to aim for. So just a little bit for the radiation oncologists or people who don't know a lot about radiotherapy. We've come a long way with a history of CNS radiotherapy planning. And at the start of all this, it's important to note that some centers will still be doing 2D radiotherapy planning. But this is how radiotherapy started, with us using plain films and x-rays. So bony landmarks were used to target the radiotherapy. And you couldn't calculate what doses were given to the organs in the area or close by. So when we say no DVH, that's a dose volume histogram. And when you do 2D radiotherapy, you can't calculate on a graph the DVH, what the normal organs or the target for that matter are getting. And you don't know what your coverage was like. So you irradiate with bony landmarks, but you don't really know what dose you're getting. But this is how we started off. And then just to show you how neuro-oncology, but radiotherapy in general has evolved. So if you look, this is a patient, he's a young boy who's 8 with a grade 2 pyelomyxoid astrocytoma. And he had a relapse after second surgery, so the decision was made to proceed with radiotherapy. So we actually treated him with a plan on the right of the screen, but if you look at the image on the very left, that axial slice shows you a parallel opposed field, which is simulating what you'd get if you did a 2D plan, and you see the dose go straight through the brain, treating the temporal lobes and not really targeting our red, which is the target. The middle image will show you slightly more sophisticated radiotherapy. So now we're directing the beams from an angle, and you'll see those little triangles. We call those wedges that help us modify the dose. So that's a wedge pair, and you get better coverage and more brain sparing. And then the last image is what we call VMAT. So we've got 2 arcs treating the patient, focusing the dose and painting it around the target. So now you can see the dose that we want to give is perfectly within the target, and we're sparing the tissue immediately outside of it. This is just showing you the high doses of radiotherapy. So there will be low doses still in areas of the brain, but we can control this with this arc modulated type of radiotherapy. So you can get the ideal dose coverage as well as the perfect tolerances to your organs. So we have come a long way. Sorry, my screen's in the way. There we go. So this is some data from one of our master students. So when you do a radiation oncology degree, you do an M.Med with your College of Radiation Oncology exam. So this is some data on our medulloblastomas. And if you see, so that this was patients from 1985 to 2015. So a large number of patients. So we know medullos are the most common embryonal tumor, and that the standard of care is maximal safe resection. And then you stratify the treatment with risk adapted radiotherapy and chemotherapy. The type of risk adaptation do would be if you were following the old modified Chang system, which I think a lot of Africa is probably still doing because we don't have access to full molecular testing. Then we'd have average risk and poor risk, and we give the average risk the lesser dose of radiotherapy, whereas a poor risk would get the full dose radiotherapy. Now, the standard of care is to try and do the molecular testing so that you know if it's a Wind sonic hedgehog group 3 or 4 molecular fingerprint, and then stratify your treatment as such. We haven't got there quite yet. We come close with some of our immunohistochemistry, but we still use the Chang system as our staging as our basis. So this just shows, I've just put this across here, just move my my Zoom camera is in the way, but so you can, if you look, you'll see that the different decades from 1985 to 95 and so forth, we got better at not doing just biopsies. So, for example, if you look at the first decade, we had incomplete staging, whereas no one had incomplete staging in the last decade. The average to high risk was closer than previously, so we got better at surgery. And then here, the extent of resection. So if you look in the first decade, we had 20 patients out of the total of 52 which had biopsies. But if you look at 2005 to 2015, only 5 patients out of 49 had biopsy. So getting better at operating, probably intraoperative monitoring, better imaging. And these developments of these techniques showed gradual improvement in survival over the following decade. So I'm just going to go to the next slide. So this slide will show you, these are the following years, and you'll see the 2005 to 2015 overall survival was the best. So this was an audit, a single institution audit of our Modalo patients. And since 2015, we're probably treating all of our Modalo patients with a VMAT boost. So it'll be interesting to see how the next decade does. Important to see is that our survival rates were slightly less than the sort of European and American survival rates, but we still fared pretty well. Okay, so moving on then to ependymomas. So this is also from one of our trainees who's now a radiation oncologist. She looked at the ependymomas that we treated from 1983 to 2013, just showing a spread of patients. So she had 51 patients, a male predominance, and mostly in the posterior fossa, and grade 2. And we had a large number of localized disease patients. And most patients got adjuvant radiotherapy, which is the standard of care for ependymomas. So the time to progression, the overall survival for these patients was good, coming up to 3 years and probably longer, but I don't think her study actually went further than that, but that's what we expect for ependymomas. If they have localized disease and have surgery and radiotherapy, they do well. These two graphs to show the overall survival according to the surgical resection. So if you had a gross total resection, you did better, just further reinforcing the fact that surgery is the backbone of the local control for an ependymoma. And then looking at the graph on your right, adding radiotherapy had a huge benefit. And we know that because adjuvant radiotherapy for ependymomas is the standard of care. So again, our single institution audit fared similar to other data. So moving along, just to mention the late effects of radiotherapy. Obviously, these are vital when you're radiating the brain of a child. Neurocognitive and neuroendocrine being the biggest, and hearing and hair loss coming up in the list as well as secondary malignancies. There are others, and if we were radiating outside of the CNS, we'd worry more about growth, but these are the big ones that we look at when we're looking at the brain of a child. And I've just put this in. So as we've gotten better at sophisticated radiotherapy, we've learned how to dose paint and spare organs. And I just show here an MRI. So we use a fused MRI with a CT scan where we draw the areas of the hippocampus that we want to spare, because those areas we know have got this pluripotential cells that can then migrate.
Right.
Hi.
So, yeah, please can you start rounding up?
Sure, no problem. I'm getting there. So those are the areas we spare. And then this is just showing pituitary sparing. So trying to prevent neuroendocrine deficits. So again, if you're treating the brain, you can try and spare the pituitary. So you'll see this patient's pituitary is outside of that dose, whereas this one is in. So again, preventing a late effect. I've just put this is a child at our center. You'll see this is the 3D plan. So you've got dose going through the abdomen. And this is what we are now starting to implement. It's a VMAT CSI plan. So still treating the neural axis, but getting all the other organs within tolerance. So this should be what we aim for, but the QA and physics is quite intricate. I know I need to round up, so I'm just going to show you some of our team. So this is what we did for Gold September. That's Professor Parks and myself with the teddy bear collection and our gold balloons. And then here's our pediatric brain tumor workshop, which we have once a year. And then the rest of our team members. I just put this on here. So hoping that this meeting will lead to more collaboration and new horizons on the continent. And if anybody wants to contact me, sorry, just blitzing through a little bit of what we do, time won't allow more. You're welcome to email me. That's me done. Thank you, everyone. James, I'll hand back to you. I'm just wanting to check are we going to go to Rakesh now? Because
yes, please.
Yes, okay. So let me introduce, I'm going to do the next introduction and James will introduce Claire. So Rakesh Jalali is a colleague. We know him well from he was the keynote speaker at the first NOSA meeting in 2018, but his repertoire is much larger. So he's a clinical radiation oncologist at the Apollo Proton Center in Chennai. But prior to that, developed the Neuro-oncology group at Tata Memorial Hospital. He's also the founder of the Indian Society of Neuro-oncology, which was in 2008, was the general secretary and subsequently the president. And Rakesh is renowned for promoting equitable cancer care in India. So he also was the founder of the Brain Tumor Foundation in India. Thank you, Rakesh, for joining us. Sorry, I know it's like 1 o'clock in the morning in India now. I'll hand over to you to tell us about situating the low middle income in the WHO classification. Rakesh.
All right. Thank you very much, Dr. Naikar, James, everyone. And I'd like to begin by expressing my appreciation to the AOTIC for having the neuro-oncology session in this very important meeting. The world has come actually now quite close, especially in the last few years, and precipitated by very unfortunate, but nevertheless in a kind of a digital space. I was given the task to talk about the latest WHO 2021 classification, particularly its relevance to the lower middle income countries. And when we talk about LMICs, we obviously know that there's a fair amount of diversity even within the LMICs. And a couple of years ago, my colleague, Dr. Gupta, we were invited to kind of compare the epidemiology and outcomes in neuro-oncology between the East and the West. And we brought a few people together, including Dr. Buffet and others from the different parts of the world. And over a period of time, we also realized some unique differences between, in this particular slide, I'm just showing the Indian data, but it could also reflect a classic or a typical LMIC in any part of the world. So for example, there were some differences in the demographics. We also collected the data, especially in our center, as to what could be the outcome data. And we looked at the gliomas, the GBMs, the brainstem gliomas, the medulloblastomas, the low-grade and benign tumors, meningiomas, and pituitary adenomas, and so on and so forth. The Indian Society of Neuro-oncology was an effort to harmonize the effort in a fairly large country with a fair amount of diversity of care and resources available. And very quickly we realized that we have to come out with very practical guidelines to particularly to address the rapid changes that were occurring in neuro-oncology in general. So the first guidelines were on medulloblastoma in 2015 and 16. In subsequent to 2016 update, we tried to introduce several markers, and I'm glad that at least in vast majority in the country, as a matter of routine pathology service, at least we are able to do the IDH, even if it is with IHC, ATRX, the P53, GFAP, and the MIB1 index, which kind of takes care of vast majority of the differentiation of the gliomas. We went on to look at even more intricate subjects like primary CNS lymphomas and intracranial germ cell tumors. But coming back to the molecular markers, several centers also had the ability to do 1p19q loss, particularly to establish the diagnosis of oligodendroglioma, although it was relatively expensive because you need a FISH, MGMT promoter methylation, and many centers in the country also started using the BRAF mutation and BRAF fusion, especially relevant for pilostics. And in some other centers also looked at even more kind of difficult markers like TERT mutation. Eventually, we came out with what are kind of a very practical adaptation of the 2016 guidelines, was published in 2017-18, and kind of gives us a very relatively simple way how to deal with the changing landscape, integrating the diagnosis morphology with respect to particular relevant markers and looking at the resources. The IHCs became quite, it was not so difficult. And the IDH was roughly about $20, $25 in typical laboratory, and you could get everything done in about $100, $150 US dollars, or about 5,000 to 7,000 Indian rupees. You could get most of the diagnosis, especially in gliomas. As was mentioned by both the speakers, absolutely critical to have multidisciplinary meetings. It has resonance in practically and virtually all brain tumors. I gave an example of low-grade gliomas because low-grade gliomas, particularly the diffuse gliomas, it has made quite a bit change with respect to the IDH mutation and 1p19q co-deletion, which are now called oligodendrogliomas, because oligodendrogliomas have to have IDH mutation and ATRX retained. Now, if you have ATRX retained and IDH mutation and also have a typical morphology, you don't necessarily need to do 1p19q. This was what was published in our ISNO guidelines because they have the best prognosis. The IDH mutant 1p19q non-co-deleted or ATRX loss of ATRX expression tells us typically an astrostic lineage like a low-grade, grade 2, grade 3 astrocytomas, and they have an intermediate prognosis. The ones who are non-co-deleted, obviously IDH wild type, they have the poor prognosis. They behave almost like a primary glioblastoma. Mind you, though, about 10% of IDH mutation may not be seen on a IHC, has to be confirmed by a sequencing. But again, you don't need like a very elegant whole genome sequences. You can do targeted Sanger sequencing by RT-PCR, which is again not so difficult in many of the laboratories. But everything has to come together only after you discuss the relevant clinical and radiological features. I like to demonstrate it by a case example. A 34-year young lady who presented rather acutely with raised ICT and was initially thought to have an arachnoid cyst. The pathology was reviewed. It was IDH mutant. So obviously means it was a grade 2, grade 3 tumor. There were oligo-looking like cells. ATRX was retained. However, 1p19q was non-co-deleted. So the final diagnosis as per WHO 2016 came out to be anaplastic astrocytoma. This patient was actually was treated somewhere else, came for a second opinion, and I was struck by the retention of the ATRX. We repeated her MRI, got a re-resection done with the residual tumor. It was only a partial resection. And in the review, that not only was the 1p19q co-deleted, obviously had IDH mutation, the morphology was like a classic now anaplastic oligodendroglioma. And we know how different the significant change in our prognosis for about 3 to 3.5 years, what you would expect in an anaplastic astrocytoma to anaplastic oligodendroglioma. Because it had a favorable molecular profile, the median survival is more than 15 to 17 years in the current series in various trials and various studies that have been done throughout the world. So that brings us to the latest WHO classification, emphasizing that 2016, mind you, was only an update. So the formal 5th edition of 2021 actually is a formal 5th edition, the blue book, so as to speak, and emphasizes the importance of integrated diagnosis, which was suggested quite elaborately and quite elegantly in the fourth edition update of 2016, and also defines many new tumor entities. I have to say it's quite hard to grapple with the entire 2021 classification. Dr. Balogan showed us about the pituitary adenoma nomenclature to be changed into pituitary neuroendocrine tumors, also PIT NET. But also many other tumors have also had significant amount of change. One of the two important things what have been changed is that instead of the numerals, now it will be called 1, 2, 3, rather than the Roman numerals, because sometimes there was a difficulty in that. And the second difference is that if you have a grade 4 tumor, but is IDH mutant, it won't be called glioblastoma anymore. It will be called grade 4 astrocytoma. So the IDH mutant tumors could be oligodendrogliomas, but have to be confirmed with ATRs retained or 1p19q co-deleted. If they are ATRX loss, then they will be astrocytomas, and they can be IDH mutant grade 2, grade 3, and grade 4, even if they have a classic morphology of necrosis and they have microvascular proliferation, as you will see in glioblastoma. But because they are IDH mutant, they will be called grade 4 astrocytomas, will not be called glioblastomas, so as to because they have a better prognosis and also could have possibly some therapeutic implications as well. Now, case 2 in this particular presentation was a 47-year-old lady presented many years ago, more than 10 years ago, with a glioblastoma. The MGMT promoter methylated after surgical resection, received radiation plus temozolomide, did relatively well, had a recurrence, was reoperated upon and followed with radiation chemotherapy. And what I want to highlight is that there were some percentage of changes which were treatment-related changes. We always ask our pathologists as to what is the percentage of treatment-related change vis-a-vis active tumor, and also had MGMT promoter methylated. In the WHO new classification, as I mentioned, eliminates the term glioblastoma, but still does not include MGMT methylation in the new classification. Sometimes this is useful for different therapeutic, challenges that we see in our clinical practice. I quickly bring to the case 3, which is a case of a 37-year-old lady, writer by profession, had seizures in September 2020. You can notice a kind of a mesial temporal lobe lesion, a temporal craniotomy, and gross total excision in February 2021. The histopathology looked like what was IDH negative, which was quite strange. I would have expected an IDH positive in this case in a young lady. P53, CD34, all were non-contributory, and the MIB1 index was 6 to 8%, was actually called anaplastic variant. We dug deep into it. We tried to rule out the histone by Sanger sequencing and also did the BRAF. And lo and behold, the BRAF V600E was mutant. So the diagnosis changed from an anaplastic astrocytoma to an anaplastic pleomorphic xanthoastrocytoma, which clearly has a slightly different biological behavior and also could have possible therapeutic implications. We also have realized the importance of BRAF mutation in pilostic astrocytomas. Only 10 to 15% will have V600E mutation, but about 70 to 80% will actually exhibit a BRAF fusion, particularly at this locus. And this is very, very important, and WHO 2021 identifies different kind of nomenclature for pilostic astrocytomas. The B600 mutation is mainly in PXA ganglioglioma and also in epithelioid glioblastomas. What I also want to point out in the new classification, there is no grade 2 pilostic like erstwhile we used to call pilomyxoid. Most of the pilostics will be clubbed as grade 1 pilostic astrocytomas, preferably shown to have BRAF fusion. But there will be a percentage of patients in slightly older people in the posterior fossa, but sometimes in supratentorial region as well, who would have high-grade astrocytomas with piloid features, and they are grade 3 tumors. And we see some of the pilostics sometimes not behaving so well, and this is the type of tumors that has been assigned. The therapeutic implication, of course, is that now we have targeted therapies against both V600E mutation and also MEK inhibitors, particularly for BRAF fusion. And this has taken quite a bit of attention, and we have already started in our country some of these markers, and also the drugs that we use, dafragunib and trametinib. They are very, very expensive, very difficult to get, but hopefully with the period of time and more patients getting it, the cost will come down. Briefly, a diffuse midline gliomas or the diffuse pontine gliomas, always very difficult. We realized in 2016 that vast majority are H3K27M mutant, but we also realized there could be other histone mutations or histone alterations. So the 2021 classification actually suggests that instead of mutation, we call it histone altered, and this is seen in 80% of the cases. We also are very excited with some targeted therapies, particularly the dopamine antagonist and ONC201, and some of these patients are being tested in various clinical trials throughout the world, and hopefully otherwise very, very difficult tumors to treat. Maybe some of these patients will get better treatment and better outcomes, primarily based on the discovery of the mutation, and also very importantly, discovery of the targeted therapy against this mutation. My final case is a 14-year-old boy who had a rather infiltrative tumor on the right side, very large, almost like a gliomatosis in a relatively young child. And enhancing, had a temporal lobectomy, could not remove, resect everything, actually had proton beam therapy, showed a very good response eventually. But mostly we were kind of struggling with the pathology because it was looking like a glioblastoma, but then ATRX was lost and IDH was negative. It didn't make sense because if ATRX was lost, IDH should have been positive like a grade 4 astrocytoma. And this was the struggle. And MGMT was methylated. And then it was quite evident that he had harbored what is called hemispheric gliomas or histone gliomas, or frequently called G34 gliomas. So this is a new entity called the hemispheric glioblastomas. 50 to 60%, interestingly, have MGMT promoter methylated. Typically, ATRX loss, looks like a glioblastoma, has an intermediate prognosis, not as bad as the usual glioblastomas, but of course, not as good as other tumors as well. Very recently, two very elegant papers have come showing targeted therapies against this G34 mutant, particularly the PDGFRA. So we are already, this child is now receiving a targeted therapy with dasatinib. And some of them also can have CDK4/6 mutations, and there are some molecules looking at these kinase inhibitors as well. Finally, we know the evidence of medulloblastomas, how critical it is to have different groupings, and many parts of the world have used different methodologies. Many of them are IHC based. In our country, we also use the real-time PCR based. But also I want to draw your attention, which is maybe relevant to LMICs, is that we did this prospective blinded study, which was published a couple of years ago, based on 130 odd patients, where we looked at relatively simple radiogenomics factor, not very, not the spectroscopies.
Okay. Sorry to interrupt. We're just going to have to round up in a minute to give Claire a couple of minutes before our session ends.
Sure, I'll just wrap it up. So this could be one thought that can help. And this is also some relevance to de-escalating therapy. Similarly, with ependymomas of PFA versus PFP and the importance of 1Q gain. So in summary, developments in molecular markers and incorporation of 2016 has been useful, and it is a need for routine clinical practice, and it's been realized in some parts of the world. Also sensitize the neuro-oncology community, both the clinicians as well as the pathologists and basic scientists, to bring them closer and growing collaboration. Diffuse gliomas, ependymomas, pediatric gliomas, and medullas, much better understood and managed in current practice, and 2021 is a natural evolution. At the same time, however, the pace of development seems to be frenetic and is definitely intimidating to the clinicians, pathologists, patient advocates, healthcare planners. It is very important, I would argue, to just take a little pause, incorporate the new entities, integrate the relevant information in practical guidelines, and evidence-based care has to be done judiciously and thoughtfully. And for LMICs in particular, it is such a huge challenge because we have to balance the rapid developments of the field and the availability of resources, both the material resource, but also the training of the human resource. And it can come only with more collaboration, which will give us more power, eventually translating into the benefit of our patients. With that, I thank AOTIC and all the facilitators and this conference organizers for giving this opportunity. Always a pleasure to be part of all your meetings. Thanks very much for your attention.
Thank you, Dr. Jalali. Always a pleasure to hear from you, and obviously, well elucidated lecture. Obviously, I hope we do have some time to really talk about this, but I'm going to quickly introduce the last speaker, who is one of the rising stars in the sub-Saharan African continent, both in neurosurgery and neuro-oncology. Claire Karokezi, she trained in neurosurgery at the WFNS Rabat Center in Morocco, and then had her further training in surgical neuro-oncology at the Toronto Western Hospital in Canada. She's presently at the Rwandan Military Hospital in Kigali, and present chair of the Women in Neurosurgery of the Continental Association of African Neurosurgical Societies. Claire, please do take over and do justice to the topic, the changing landscape in the management of meningiomas. Thank you.
Thank you, James. Is everyone able to hear me?
Yes, we can.
Perfect. So, James, thank you for inviting me, for adding me to this session again. And I know you gave me a hard challenge to talk about this topic, but I love meningiomas, as he always says. And I'm glad to take you through maybe the latest changes, even if they remain very challenging for LMICs, but we'll see what we can do in the future. So I'll be talking about the changing landscape in the management of meningiomas. I'll start with a little bit of background. So we all know that meningiomas were described by Harvard Cushing in 1922, that they are the most frequent primary CNS tumors, accounting to more than 35%, and that they come from the arachnoidal cap cells, which are on the arachnoid layer covering the brain. That 80% of these tumors are slow growing, most are benign, but lately we have seen many papers talking about some subtypes which are described to be benign, but which will show a less favorable outcome. So they will tend to recur quickly, and they tend maybe to have malignant transformation. So this drove many researchers lately, and we'll be seeing this in my presentation. So usually the prognosis is good, often due to this benign characteristic of meningiomas and the slow growing pattern, but also depending on the tumor location, meningioma usually can be cured surgically. So that's what we know about like convexity meningiomas. You remove it from a young woman, you have cured her. But we have seen other locations that are very challenging. So it has believed in the last years that the extent of resection that was classified by Simpson grade, that was a strong predictor for tumor recurrence, but now it's changing because we have seen many tumors that were very great resected, but that tend to recur very quick, and they tend even to have malignant transformation. So this brought people to think that maybe there's something else in meningiomas that we haven't seen apart from being surgically resected. So these are some numbers. We know that, as I said, most common tumors, majority are benign. About 98% are intracranially, but can be also in the spine. Up to 2.3 individuals are diagnosed with asymptomatic meningiomas. And we know that women are more affected and that this incidence increases with age. There are other risk factors like NF2, exposure to radiation, contraception, hormone therapy, and all these other associated syndromes. And presentation usually depends on the location, but usually they tend to present with partial seizures, headache, personality changes, and other motor deficits. So these are the symptoms that meningioma presents with, depending on where they are located. This is a paper that was published by Nanda and team in 2017, showing all the possible location of meningiomas. So when they tend to be at the convexity, they're easily removed. Parasagittal also easily removed, but the relationship with the sinus sometimes make them tricky. And then when they tend to go to the skull base, they become even more challenging surgically, even though they may be benign tumors. And that's what I was saying, that we believe for a long time that gross total resection was the cure really for meningiomas. But molecular studies lately looked at this, and we have seen a lot of changes, especially in the CNS5. So this is the classic histological classification, where the tumor was usually classified depending on how it presented, its severity, density, mitosis, necrosis, or presence of brain invasion. So we, tend to say benign or malignant or intermediate. And the WHO grade was in the beginning thought to be a good prognostic factor. So this is the 2016 grading system. And you see that grade 1, most meningiomas are grade 1, and they tend to have a PFS that is at least above 75, and grade 2, shorter PFS, and grade 3, almost zero progression-free survival at 10 years. And then new papers started coming in, and that drove to the 2021 WHO classification that asked us to include all these tests. For instance, you will see that meningioma that express the third promoter mutation will tend to have a worse prognosis. And this was studied by several teams, including our team in Toronto, ZADM team. And they looked at DNA methylation profiling meningiomas, and they found that this DNA methylation profiling gave more information on tumor prognosis rather than the WHO. You will see that some groups, even though we say like we have WHO grade 1, grade 2, grade 3, but there were some subgroups in this grade that showed either favorable or unfavorable outcomes. And this led to this recent paper that was published in Nature, I believe, in July, that brought these molecular groups. So they described 4 molecular groups, and they keep the 3 WHO classifications, so grade 1, grade 2, grade 3, but you will see that among, especially grade 2 and grade 4, you will have some subgroups, 3 and 4, which have a bad prognosis than the 1 and 2. But even in what we thought were benign meningiomas, grade 1, look, there are few that may be grade 3, so which means that they will have a bad prognosis than the classic meningioma we know. So these molecular 4 groups were identified, and overall MG3 and MG4 show shorter time to recurrence, and they have most unfavorable outcomes, especially for MG4. And these molecular groups prognosis was independently, this is an important factor associated with the WHO grades, the PFS from the WHO grading system. So you will see that we really need to be able to do this prognostic to profiling tests to know how these meningiomas are behaving. So this is a case, I believe I presented it in the SNOSA tumor board. This is a man who had the frontal meningioma extending to the anterior skull base. I resected, complete resection. The pathology came because I couldn't do all these tests as a grade 2 atypical meningioma. But since I believed I had a clean post-op CT and I had a clean MRI at 3 months, I decided to observe this man. But you see that at 1 year, there were 2 small new lesions. So this, again, brought me to think, what if I had a DNA profiling of these tumors? Maybe I could have offered an upfront radiation, because maybe this tumor behaves a little bit differently from other atypical meningioma. And the other point that is changing is upfront radiation for atypical meningiomas, whether they have a good or a bad prognosis according to the DNA methylation profiling. So some studies have shown that it's people who are offered upfront radiation do better than people who are not irradiated. So that's another thing we need to know. Are we going to irradiate all grade 2 meningiomas, whether they have good, favorable methylation groups, or are we going to wait? So as we get more series and as we get more studies, maybe we'll have answers. So, concluding, I think I've said it all. So most common intracranial neoplasm, benign majority, but we have seen changes in molecular subgroups and changes in the CNS5, and the effort in molecular profiling, which are driving to new trials, and probably we're going to get potential future targeted therapies. And I hope we get something that can be done in LMICs, because it's still difficult to do all this testing. I still resect meningiomas, but all I can get is the classic grade 1, grade 2, grade 3, grade 4, grade 3. So I don't know where we're going to get to have a full DNA profiling testing. Thank you.
Thank you very much, Claire. I hope you can hear me. My network is kind of fluctuating. All right. Thank you so much, and very much thank you for taking out your time despite all the difficult schedule and the travels today. So basically, this Claire is the last speaker for today, and we will just look into the chats, the question box to see if there are questions. But I got 2 quick questions, one each, one for Turan and the other one for Dr. Jalali. So for Turan, with respect to growth hormone replacement, what are the challenges that you have in South Africa in terms of access to growth hormone for those patients that you have to do radiotherapy for, even though I know that you were doing some pituitary sparing radiations, but how frequently do you get to see these patients with growth hormone, needing growth hormone replacement, and how do you source for it? I know it's some challenge on sub-Saharan Africa. And then to Rakesh, so basically I want to find out what your thoughts are about molecular GBM, where there are absolutely no histological features that suggest high grade, but then you do have this TET mutation, EGFR amplification, loss of grade, gain of 7, loss of 11, and then it's automatically GBM and should be so managed. I know that a few pathologists are wary in terms of you don't see GBM on the slide, but then you have to go ahead and tell the patient that you do have GBM, obviously. And then the second part of the question is, I haven't said so much, your last statement says the 2021 classification is valid and justified. So the big question is in sub-Saharan Africa, as well as the whole part of Africa, how do we get to develop, to get into the mode of this classification, which is essentially, again, what Claire has done. And it will be obvious that we're going to move far away further with the methylation profiles being introduced as part of the classification that will change the whole landscape completely. So I'd like to know what your thoughts are. So I'd like Turan to go first.
Thanks, James. Mine is not long. So we don't seem to have any difficulty getting growth hormone in Cape Town. So we have all our children followed up in that MDT. And if anyone fails the STIM test, then and they don't have a tumor that's growing. So if the tumor is under control and they need growth hormone replacement, they get it. So we monitor them, their growth velocity, and if they need it, they get it. There isn't a problem getting it. The craniopharyngiomas, there was some kind of mixed thinking that even if they were in remission, perhaps growth hormone could actually switch those tumors on again. But that seemed to be sort of anecdotal. So actually, any tumor in remission with a child that's growth hormone deficient can get growth hormone, no problem in Cape Town. I don't know about other places. I'll let Rakesh answer his question.
Yeah.
It was longer.
I just want actually one comment on growth hormone. It is actually a very relevant question and in vast parts of LMICs. And certainly I can tell you in India, there's a tremendous amount of challenge because neither the state nor the private centers nor the insurance actually covers growth hormone replacement. And I run the foundation and the survival clinic, and it's very sad to see a child coming up with a cranio or a medullo or ependymoma or some other child who has had surgery and radiation and chemotherapy doing very well. Scans are looking great, but child is stunted. And it's a fair amount. It's very expensive to have GH. So we did a campaign from 2015 onward to raise awareness and money for the GH, and a substantial amount was raised throughout the country, and to also sensitize to the healthcare planners and authorities to look at it an extremely important, relevant survivorship endpoint. So sorry about that. I couldn't resist throwing my 2 pennies on the subject. Now, James, you asked very, very difficult questions, and they are extremely relevant, extremely important, pertinent, and which dominates our everyday discussion in a clinical point of view. Vast majority of the GBMs, if we are really very practical, the usual, the 60s and 70s and 80s people that you get, you don't need to do the whole thing. Because there is very little therapeutic implication on that. So you would just do most of the things that we do. But I actually, what is very interesting, which I try to show, in fact, the MGMT promoter methylated helps a lot sometimes, both in the elderly population, but also sometimes in the younger patient population. And that still is not incorporated even in 2021. And I presume because of the differences in platforms and challenges to perform with fair amount of accuracy. But in some GBMs, particularly in lower grade gliomas, I would say grade 2, grade 3, to have just IDH, as I just mentioned, ATRX, and to have some kind of sequencing is, I think, at least critical, is actually basically what the WHO 2016 taught us and has been kind of validated and confirmed by 2021. So while 2021 has thrown up lots of new classifications, but to me, it is actually the validation of 2016 in many ways, which should be incorporated into routine clinical practice. I gave you an example of a child of 14 where the pathology was not fitting at all, looking at different modalities. And we just did a small targeted sequence on G34 and it was promoter methylated. And now we have a drug against it. Same with diffuse midline gliomas and so on and so forth. A lot has been said on DNA methylation, and Claire gave an outstanding presentation on the meningioma part of it. And it's very hard to incorporate methylation in a routine clinical practice. I think it will be a step ladder approach. If we have our basic molecular pathology markers, have our good MDTs, and we cannot afford to have the methylation profiling on gene sequencing on every single patient, but use the resources judiciously driven by clinicians. What is happening sometimes is that in the effort.
Okay, sorry, if you get cut off, we're still listening to you, but the conference is saying they may cut us off just now. So.
So essentially, we have to be pragmatic about the whole situation and go very stepwise in a judicious manner. Rather than subjecting every single patient on methylation, I would rather use very smartly and intelligently and have 100 patients rather than spending all the money in one patient on methylation. And that should be the way to go forward.
Thank you very much, everyone.
Well, thank you very much. And that once again promised to be a very, very riveting session. And I think what we can certainly take away from that particular session is multidisciplinary teams, once again, treatment protocols, evolution of practice over time, evolution of science, certainly, that can impact therapeutic choices and molecular profiling, or certainly benefiting even neuro-oncology as we move forward in current times. That brings us to the end of the current day. Certainly, Zainab, it's been a day that has been full of surprises, but we've come to the end of it. And before we end off this particular session, I just want to please remind all of the delegates to please engage on the virtual platform of Aortic, the agenda, the program, all the information regarding the speakers online, the resources, as well as the networking engagement. I think it's important for you to use the networking hall and take opportunity to interact with all of the speakers that have participated. I'm also told that there's a treasure hunt. And it's fun. So if you want to perhaps try a career at being the Tomb Raider or perhaps even Indiana Jones, I'm told that there's a serious prize to be won. So please go ahead and take a try at something new. So all that's left for me to do is, on behalf of myself and my co-host, Zainab Mohammed, is to bid you a very good night. And we'll see you tomorrow, bright and early at 10 a.m. And I can assure you it promises to be another riveting day. So a very good night to you, coming to you once again from Cape Town Studios here in South Africa. Good night.